Welcome. It's May 16th, 2021. I cannot believe here we are, the middle of May, and it's been a little while since we've all been together. Happy belated Mother's Day. So glad to be back together. Thank you, Glenn. Glenn Grossman is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years, and he taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology forecasting and advanced analytics with Bristol Myers Squibb, Sanofi, Novartis, Medicare, Medicaid, Veterans Health Administration, Military Health Service, the CDC, and other programs within the United States and abroad. And as many of you know, he's been our esteemed tour guide through this COVID epidemic for many of us for this year and a half, or almost year and a half, I should say, right? Year plus. And we're so lucky to be back together. And as always, all views expressed are his own. So Glenn, as usual, please give us an update on where we are with this pandemic. When we were last together, we were talking about the major variant of concern in India. So maybe you can start there or start in the US as you normally do and take us abroad.
Yeah, let me share my screen. Yeah, so unfortunately, in fact, I can talk a little bit more about this tonight, but unfortunately, there are now numerous variants in India. And some of them are even a little bit more scary than the earlier ones now. Then we'll talk about that a lot today. But yeah, so let me jump in over here. This is a global snapshot, so let's just jump in. So much of the world is doing very poorly. So this is total new confirmed cases. I took this snapshot a few days ago, but basically you can see India, South America, much of Europe, lots of different places are not doing very well at all. Some are doing particularly poorly. When you look at, so this is the total number of cases. When we look at the rate of spread, so where is it getting worse? You can see that in some countries in countries that are blue, it's getting better. And in countries that are yellow, orange, or red, it's getting worse. Red being getting worse at the fastest rate, yellow just getting worse at a mild rate. And then in terms of whether it's out of control or not, we have a snapshot here in terms of how much testing, that the testing positive rate, because if the positive rate is high, then it means that a lot of cases are not even being tested at all. Typically what you're shooting for is like a positive test rate of like 3 to 5%, because that means that you have a widespread testing. And in much of the world, they're doing so little testing, it's kind of irrelevant. So that means that the cases that they're reporting are not even accurate, that there's way more cases happening than they're reporting. All right, so and the death rate too is also corresponding to the high morbidity rates, as you'd imagine. But surprisingly, in some places, South America, it's been a lot of COVID when it's again that we started seeing this last summer. It's currently their summer, so they should not have a lot of cases right now, and yet you can see that they're having a lot of cases and a lot of mortality as well. It's not just cases. So this is very disconcerting. We've talked before, and we can talk a little bit more tonight, that we're typically following the pneumonia seasonality patterns, and that's fall, winter type of seasonality, early spring. And so the fact that this is happening is crazy. All right, here we're looking at the vaccination rate. So globally, this is within each country, you can see who's gotten at least one vaccine. And you see that there's a couple of countries that are standing out. Here's UK, Chile down here. You can see Israel over here. There's a few, I think it's Bahrain, that are a few standouts that have done exceptionally well. United States is catching up. This is the share of the population that's fully vaccinated, 2 doses. So in Europe, you'll notice that UK, for instance, they really prioritized getting 1 dose. whereas other countries really prioritize getting the second dose. All right, let me jump into the United States. So here's two graphs that I've overlaid. The United States, the cases are in the blue and the red line. And so these are the total number of cases. You can see that we're going down at a fairly good clip. This is corresponding with the seasonality. So we've known that the seasonality is a really strong predictor. And so right now we're leaving the typical cold flu season and the pneumonia season. And so as a result, that's the single largest driver of the cases going down. The yellow line is the death rate, or not the death rate, it's rather the number of deaths. And we still see that lagging behind. You see that when we have the two curves of the cases here and then the deaths, there's a lag between when people get infected and when the deaths occur. So we still expect a lag. Because of the vaccinations, we expect that the death rate and the number of deaths will start coming down more rapidly than the cases, but that's still to be determined for a bunch of reasons we'll talk about. In terms of the spread, how fast is it spreading? Not how many cases there are, but how fast is it spreading? In fact, this is a good time to switch over to this. All right, so this is where the spread is occurring the most. And you see that there's some states that the spread is actually occurring at a faster rate per person. And so some countries are or rather some states are in the clear for the most part, where not only is it a good, the seasonality effect, so the numbers are coming down, but also the transmission rate is very low. Whereas in some states, we shouldn't be seeing what we're seeing, where there's still quite a lot of transmission. At a high level, whoops, here's a state by state view. So this is the total number of cases, not the transmission rate, but the total number of cases. And you see that some states are in a worse condition than in others. The death rate is a little bit different. I'll just come here. But you see that some states are not doing as well in terms of death. Part of this could be in terms of the discrepancy between the cases and the deaths that we're looking at. Part of it could be, again, going back to testing, that it could be that the sickest of the sick are the ones getting tested. And so the cases that we're identifying are the ones more likely to die. Whereas in others, if they're doing a better job of testing, then they'll identify more cases, but the cases they identify are less severe. All right, let me go from there. There were a couple other things I wanted to just talk about. So the region, so this, we looked at this previously. This hasn't been updated in a couple months, but this was the COVID tracking project. And I wanted to return here for a second, because one of the interesting things that sort of violates this assumption that we're finding globally of the cold flu season really driving what we're seeing is that in last summer, if you recall, we had sort of the second surge that was occurring primarily in the South, but also a little bit in the West. And that started to pick up right around here, right around the middle of June is when it started to pick up. And so it's still an open question in the United States, what will happen here during our summer? And it's a complete open question. No one knows for sure. There's basically two hypotheses. What the first hypothesis is that nothing's going to happen. Enough people have gotten vaccinated, and there will not be a surge. And then the second hypothesis is that there will be a surge, and the surge will probably, if it occurs, will probably be driven by two things: people not wearing masks anymore who are unvaccinated and just not wearing the masks, and the spread continuing, and then we'll see a surge because of that. And then the second reason would be the variants. There are more variants of concern. And so this is worrisome, and so they're starting to spread a lot more. And so as soon as we start removing physical distancing and masking and that kind of stuff, the variants can explode. Let me show you here. So this, where do I want to show you? This is the thing I want to show you here. All right, so when you look here, these are the different variants. We've talked about some over time. We don't have a good way currently of predicting when a variant really occurs. When we identify it, we don't know if it's going to actually increase how contagious that variant becomes. We don't know if it's going to be more severe illness. We don't know pretty much anything about it. And so the way that we identify if a virus is more contagious and severe is we have to track it over time. And it's really hard to do this when there's only a few cases at a time. So week over week, I think this is like 2-week periods that we're looking at. So this is week ending April 10th, week ending April 24th, week ending March 27th here. So you can see over time, the B117 variant is the UK variant. It's clearly very, very contagious, and it's becoming much more common than the other variants. So it's very clear. And you could already figure that out right at the beginning. See how it jumped? B117 back in the end of January was this big in the United States, and it jumped much more aggressively than any other variant that's out there. And again, continued jumping that far month over month. So that's how we know. We just sort of look, and in other countries, they got infected, like we call it the UK variant. They found it there first, and it really took over much of the country there very quickly. And so that's disconcerting. Now, one of the things we found is this UK variant is approximately 50 to 70% more contagious than the original Wuhan variant that first started infecting the world. So 50 to 70% more contagious is crazy. This is causing a lot of problems. So I have some bad news, and this is the bad news. So now there's this new variant in India. There's multiple variants in India. The variants coming out of India all start with the prefix B.1.617. And now there's multiple variants that have been identified. There's subvariants that have been coming out of that. But in particular, there's this one called B.1.617.2. And when you look, we have so it is in the United States. It's spreading in the United States, but right now there's hardly any of it. And so you can see, so this was the week ending April 10th. There was only 0.1% of all the cases that we were screening for the variants. Only 0.1% were composed of this variant. Then the following period, which was the week ending April 24th, it jumped from 0.1% to 0.5%. So it multiplied by 5. Nothing else out here is expanding that fast. Everything else is staying. Look, if you look at B.1.526, it went from 8.7 to 8.2. So other things are much bigger. Even the UK variant went from 59.5 to 66, but it wasn't faster than that. So the fact that this is jumping from 0.5 to from 0.1 to 0.5 is disconcerting. And when you look at this variant globally, one of the reasons that India is doing so poorly is that this variant is currently assumed to be 50% more contagious than the UK variant, which makes it an order of magnitude more contagious than the original Wuhan variant. And so we've barely just begun tracking this in the United States, but it has hit the United States. It's in multiple states at this point, not even sure which ones. It's probably in more than we've even identified, because we're only capturing a portion of the variants in terms of screening. So this is problematic. And we'll talk about this some today. When we look at this, that's not what I want. So when we look at India's variant, their rise, that was all because of the India variants, and much of it was due to this B.1.617.2. And so that's really how it started exploding. And if you look, in fact, let me just focus on India for a second. So if you look at India here, you can see that the inflection point started over here around February or so. So that variant took a couple of weeks, but at the beginning it spread. So you know, say it takes, if you have an R of 2 or R of 5 that we talked about a year ago, the reproductive rate, then that would mean that if you have an R of 2, then one person on average would infect 2 other people. Or if you have an R of 5, then one person would infect 5 other people. Clearly, what you're seeing here is that if the mutation first arose, say in like early February, then that first person would infect, let's say 2 people. If the R was 2 more, let's say if R was 5, it would infect 5 people. But that's only 5 people. Then another few days later, those 5 people would infect another 5 people. Another few days later, those 5 times 5, so the 25 would infect another 5 each. So that multiplication rate, at the very beginning, the 25 people you wouldn't really notice because there's already just so many people getting infected. But then the exponential growth, once you start getting into hundreds and thousands and you start rising, then you start noticing it very rapidly. But so what we're trying to do is identify these people early on. It's already spreading out of control in the United States. We don't even know who these people are, but we're not at the high point yet. We just know it's coming. And so this precedes our discussion on the CDC's unmasking. And so we'll bring this up in a little while. That's basically it. Let me see if there's anything else I want to mention here. We've looked at the US, we've looked globally. One thing I can add is, so here's CDC cases. Let me come back over here. Rather than states, I'm going to be looking at vaccinations. That's what I'm looking at. All right, so currently around 85% of people over the age of 65 have had at least 1 dose of the vaccine, which is amazing, great. Around 73% of people over the age of 65 have had or are fully vaccinated. And so this is great news because these typically correspond with the highest risk people. There are other high risk people who are under the age of 65, but so some of them will be captured here. Among people over the age of 18, roughly 60% have had at least 1 dose, 47% are fully vaccinated. And among people over the age of 12, or let's say total population, the magic number here is 47%. What we found globally is that the magic number should be 60%. And once you get this total population number up at 60%, then that's really when you start seeing a huge decrease in transmission and that kind of stuff, which we'll get to in a little while, which is one of the reasons the CDC decided to allow masks. But we're not at 60%, we're only at 47% here. But anyway, we are at 60% roughly among those over age 18. And we do know that among kids under the age of 18, there's not a huge amount of transmission. So, okay, it's not so far off. By state, there is a lot of variation. But I want to look here as people, at least 1 dose. Let's do over the age of 18. So you can see that some states are doing very well. Look at the Northeast is doing well in blue. On the West Coast, they tend to be doing a little bit better. Unfortunately, you can see clear regional variation. The South is not doing very well at all relative compared to, I mean, they're not doing amazingly poorly relative to a lot of other countries out there. But when you look at like New Jersey, for instance, which has 70% of the population over age 18 having this protection. Remember, I mentioned 60%. So let me go back to this. 60% is the magic number here. New Jersey is at roughly 56%, so we're almost at the 60% number, and yet there's some states that are only at 35, 32. And so this is really not going to be. They're heading into the summer not in good shape, and particularly because we know the seasonality is going to hit us. It's not a difficult bet to assume that we're going to have another big surge in the coming fall and winter, and they're not on target at their current rate to really prepare for the fall and winter. And so that is what it is. All right. Are there any questions so far? Otherwise, let's just jump into the questions people have been asking, because there's a lot of good ones.
I think let's just jump into the mask question, because the data that you just provided, it's really interesting how the CDC could just announce this week that people who are fully vaccinated, and remember, we don't walk around with our cards, taped to our heads, indicating if we are fully vaccinated or not, right? This is an honor system.
Yep.
So the CDC announced that those who are fully vaccinated by honor system in those states where they are granted permission by those governments of those states, which, by the way, is not all the states. I think there's something like 5 states, am I correct?
I'm not
In something like that, plus or minus, where they can unmask in public places, right? Indoors, outdoors, wherever they want. So we're assuming it's only people who are fully vaccinated who are unmasking. What is the evidence for supporting this decision? Is there any fine print? And do the epidemiologists fully support this decision? Do you, as an epidemiologist, support this?
Yeah, well, first let's go over the evidence of why they made the decision now. So what's new now that changed this decision, the science, the evidence. And then we'll talk about the policy after that. But so the scientific question itself, should people who are vaccinated or can they remove their masks? And so remember, there's three main issues, let's say. One is the safety and efficacy, or if they're one or two. So safety we'll call one, efficacy is the second. And then the third is transmission. So if there's safety, we know that the safety is huge for the vaccines that have been given emergency use authorization. We know efficacy. I'm not going to present the slide again, but we know that these vaccines are extremely effective at reducing severe disease and mortality. And the third question was this question of transmission. If someone is infected with the vaccine, can they still spread it to other people? And that was still the open question. So let me just review this transmission question, because that was ultimately what changed the evidence. All right, the first thing that we knew was viral load. So we started realizing pretty quickly, and let me make this a little bit bigger, was that people who were vaccinated had much lower viral load. So even if they did get infected, we know that a fair number of people who are vaccinated will still get infected. Even though they won't have severe symptoms and won't need to go to the hospital or anything, a lot of people who are vaccinated will still get infected. But the infections among people who are vaccinated, in addition to being less severe, the viral load tends to be much lower because people have antibodies and the immune system is responding to T cells. And so the immune system is responding. So the viral load tends to be a lot lower. And the first evidence for this was published as an early review. When was this? Oh, it doesn't say. But this came out, we knew this already back in, this is February 8th, it looks like. So we already were starting to know this back in January. And what this graph shows us is, so this is the CT value. This is when you do a test for the viral load, how a PCR test, how many cycles it needs to go through. And the higher the number of cycles in order to find the virus, that means the smaller the viral load. So it's a little counterintuitive. But so the blue has a lower viral load than the red. And the blue are the people who are over the age of 65 or over the age of 60. This is in Israel, data from Israel. Clearly there's a difference, and clearly the viral load is lower. So this was some of our first evidence back in February that this was published, and already January they were seeing it. But so we knew the viral load decreased, but we didn't know, just because this was a clinical marker, we didn't know if that would actually be associated with a reduction in transmission. And again, the distinction is an infection viral load is whether that amount of virus in someone's body. The transmission is whether they can infect other people. And you'd assume that having a lower viral load meant that there'd be less transmission, but we couldn't assume that for sure, because it could just be a marker that actually didn't predict whether the transmission ended. So we needed to be sure. And what came out in the last week or two was a new set of studies. This is the big one. It still hasn't been published, peer-reviewed yet, but it was sufficiently reviewed by the CDC and others that it makes sense. And so let me show you this. It was called the Impact of Vaccination. I can't see it. Impact of Vaccination on Household Transmission of SARS-CoV-2 in England. So as everyone knows, in England, in fact, let me jump to that because there's a good review. So here's England. All right, here's the vaccination dose. Remember, in England, they were focusing first on just one dose because they were trying to vaccinate as many people as possible. So UK was just doing one dose. They've already vaccinated quite a large number of people, and so you can see over 50% of the population of UK has been vaccinated. And corresponding with that, there's been a dramatic decrease in the total number of cases. but that's just correlation. What's different about this study, but so this is just refresher. What's different about this study is that this study wasn't looking at the population level. It was using the contact tracers to find who was spreading it to who. And what they did was they compared people who were what we call it the index case. That's the person who had the case and then infected those around them. The contact tracer would go to the index case and see who else was spread. They identified index cases who were given the vaccine, and then they identified index cases who were not given the vaccine. And so in this case, index cases that were given the vaccine, this is the ratio of how protective it was. The way to interpret this is the number of days since vaccination. So it's a little bit counterintuitive because usually you expect the 0 to be on the left, but here they put it on the right. So here, this set of people, 0 to 1 days since vaccination, there's not really any effect. 1 means there's not really any effect. We've known that around 2 weeks after the vaccination is when you start to see an effect. So roughly at around 14 days is when you first start to see an effect. The 2 vaccines that are commonly used in UK are the Pfizer vaccine, which here is called BNT162b2, and then the AstraZeneca vaccine, which is this other one, the blue. So Pfizer's in red, blue is AstraZeneca. And you see that they have a very similar effect. And what they find is that beginning by around the 2nd week, but you can see that it actually increases a little bit more after that. So by a month later, you've already started to get your sort of peak protection. What they found is that it reduces the transmissions. This is not infection, this is transmission. It reduces transmission by around 40 to 50%. And so this is great news. And this, because of this study, this sum of evidence, this is really what pushed CDC to say, you know, at this point, we should probably open it up. So there's a couple other reasons as well. And so this is one reason. A couple other reasons, the seasonality issue. Whoops. This is just some other evidence showing that it doesn't vary by age. I just want to see if there's anything here. There might be a little bit of variation. So if the index case was infecting it, you can't tell because of the error bars, but there might be some variation in terms of age, in terms of who's infecting who. But generally, you can see across the board, everything looks pretty much under 1. So it seems like a pretty strong effect. All right, the other thing is the seasonality. So let me go to this for a second. So pneumonia, we talked about the seasonality effect here, that typically COVID-19 around the world is following a season, cold and flu seasonality, and even more striking, pneumonia. If you strict it just to pneumonia, it's that. We don't know exactly why there is this seasonal variation, but it happens every year at essentially the same time, and it happens all over. Like, so for instance, if you had a hypothesis that in the winter, that's when people spend more time indoors, then you'd expect that would explain in the Northern Hemisphere and in the higher regions in the Northern Hemisphere, that would be an explanation of why there's more cold and flu spreading. But in the southern states, where it seems like it might be reversed, where people actually spend more time indoors in the summer because it's so hot and humid out that they are inside with the air conditioning. And yet, when you look at the cold and flu season, universally in the United States, at least here, cold and flu season tracks identically across all the states. And so we don't know really what's driving it. It could be related to kids going back to school. One thing that we have found is that the cases of pneumonia, so if you look at children being in green, adults being in red, the cases in children typically occurs a little bit before it occurs in adults. So it could be that kids going back to school are spreading it and infecting other people. Whatever the reason, this seasonality you see pretty much every year, where beginning around September, it starts to grow a little bit. Then October, November, December, it climbs with typically a peak around the end of December, early January. From there, it starts to go down, and then it typically ends. So when we're looking at May, middle of May, June, it's already gotten starts to get pretty low at that point. And then certainly by the summer, then there's there's very, very little spread. So the seasonality, right now we're in the middle of May, so it's a great time. That's another reason that we're in a seasonality, the seasonal effect, if nothing else, is going to drive the cases down, even if there was no other difference. So this is a good time to do it right now, if they were going to do it. The other thing is moving from an epidemic to it being endemic. At some point, we expect that that it's just so common everywhere. The virus is so common everywhere that it's just going to become a common occurrence every year, similar to the way that the cold and flu is. So it's just going to be coronavirus is just going to keep on hitting us every year. But it's not going to be, the symptoms after people get vaccinated are going to be mostly cold symptoms for the most part, with some people occasionally having more severe symptoms, hospitalization and dying, but at low rates, similar to the seasonal flu. And so this is what we expect. So this is the other reason. All right, so this is where we are so far. This is the sum of evidence, essentially. Right now, there's still, even the CDC's guidance has some fine print. I forgot to print out the fine print here, but essentially the fine print is that people who are visiting a doctor's office, going on public transportation, going indoors in other large public places who are vaccinated should still wear their masks in those places. Other high-risk places like that where there's a lot of people, they should still wear it, because even though the transmission rate is reduced, it still exists, and so the mask should still be worn. We talked a couple weeks ago when we last met that the masks themselves, on average, reduce the risk of transmission by around 50%, give or take. And so 50% reduction based on the masks times the 50% reduction based on the vaccine really knocks it down to a lower level. So it's an extra layer of protection. So having said that, that is the sum of evidence that, also people who are immunocompromised. We still don't know how well the vaccine works on them. We don't believe that they are producing the same level of antibodies as people who are not immunocompromised, because that's what it means to be immunocompromised. So therefore, people who are immunocompromised still need to be physically distancing themselves. They need to be wearing the masks, etc. All right, why don't we switch going from there to talking about why the CDC's decision might not have been good. Is that okay? So we've been talking about why the evidence supporting it, which is really quite strong, particularly transmission evidence we just found. But now let's talk about why we might be skeptical of what the CDC said. All right, here's the first thing. Let's talk about variants. So variant evolution, we've talked about evolution a bunch over the course of the last year, because it really is a critical central issue whenever you talk about viral spread and epidemics. So viral evolution here, that the engine, the variant evolution engine is really driven by three things: cases that are occurring, how much spread is occurring. The second thing is how much selection is occurring. And then the third is the mutation rate. For this virus, we can assume that the mutation rate is the same for each person who gets infected or spreads it to someone else. The risk of the virus mutating in that one person is very, very, very small, but it's constant, let's assume. In that case, the real thing that's driving how many mutations are occurring are simply how much spread is occurring. So right now, at a global level, just in terms of how many people actually have virus in their body, we're near the high of where we've been over the last year and a half. So we are just churning out every day new mutations that haven't existed before. Just because a mutation occurs doesn't necessarily make it a bad thing or a good thing. What makes it change its behavior is the selection pressure. So something needs to happen to make a variant more successful at having offspring in order for it to become more common over time. So things that can make it more successful are if it makes a higher viral load, for instance, if it spreads more in a person's body, and then it maybe might make it more contagious in some way. So if it's more contagious and it spreads to more people, then that would be a way that you'd see it reproducing more, and that you have an accumulation. And so that's sort of called the selection pressure, and that would drive a more contagious virus. Other things that might do it is right now, this is still an acute infection. We don't have any, it's not a chronic infection that occurs, but if at some point it were to break out and become a chronic infection of some kind, then that might be a more successful strategy, because then it might be able to infect people over longer periods of time instead of just over the short window of time that we're thinking is around 10 days or less for the majority of people who are infected. And so that's what we're looking at. Right now, there are a lot of variants being churned out. We don't know what's going to become more contagious. The big slope here that's been largely driven by India and other variants, this was the India variant. That variant has now had multiple generations of offspring that have created their own new mutations and their own new variants. The problem is that the variants that we will be most concerned about in the coming fall and winter, some of those variants probably don't even exist yet. The mutations haven't even occurred in the world yet. And in the next weeks or months, they'll occur, and then they'll start being even more contagious. And so right now, that's why we keep on saying we need to get the global pandemic under control, because what's going to hit us in the fall and winter in the United States is being developed right now. I mentioned earlier, and let me jump on back because there's so many more interesting things to talk about. I mentioned earlier that the UK variant was around 50 to 70% more contagious than the original Wuhan variant. The UK variant was also more severe, around 50% or more severe than the Wuhan virus was, or variant was. We don't know how much more severe the Indian variant, this B1617.2 is versus UK, because we haven't been screening very well in India and some of these other places. But there is one thing that every epidemiologist in the world is stressing about right now. Before I tell you about this, let me just talk about the B1617.2 variant a little bit more, and then I'll jump into the next topic what every epidemiologist is worrying about. So if you look at the growth curve, this is the UK variant original growth curve in United Kingdom. So it grew very rapidly. This was before the vaccines were really getting started. And so it was growing extremely rapidly at this growth rate. The problem is UK now is widely vaccinated. There's a lot of vaccines that have been given out in the UK. Since then, the B1617.2 variant has struck, and the B1617.2 variant is exploding at such a fast exponential rate that it's actually at the same rate as the B117 UK variant was in the UK, even though all these people have been vaccinated. So despite the vaccines, it's still exploding at this rate in the UK. So it's very, very worrisome. It's going out of control. The UK right now is racing as fast as they can to have 2 doses, that get the second dose into arms of people in the UK. But this is really problematic. What I want to share with you now is what all eyes, every epidemiologist in the world is looking at this.
Glenn, can I press pause right there, everyone, before Glenn shares what all epidemiologists around the world are stressing about? Mark, could you ask your question, please, about the B16172 variant?
Yeah, just quick, Glenn, do the vaccines cover that one, or some of the other?
So we don't know. The B1, so like I said, in India now there's multiple variants. The B1617 variant, that was sort of the mother variant to the B1617.2, was not nearly as, let me open this up, was not really as contagious. So when you compare, well, this is B1617.1, it was similar to B1617.1. And yes, our current vaccines do protect against the B1617 pretty well. Not 100%, but pretty well. I haven't seen anything published, not even in the pre-press, of how well the antibodies work against B1617.2. In India, they've been talking about it, that some vaccines work better than others, but we don't know for sure which ones are which, and so it's still an open question. I think that the description that I'm about to get into, what the epidemiologists are talking about, will help to answer that a little bit. And so let's jump to there. All right, so let's talk about Seychelles. All right, Here we see the Indian Ocean, and here's India up here, Africa over here, Australia down here. Right here where this red dot is a very small island chain called Seychelles. And I think it's a great name for an island chain. That's a resort community. It's everything you'd expect in a resort type of community. The turquoise water, the palms, in terms of the trees and stuff that we're looking at. When you see the kayaking and the resorts, even the rainbow in the picture, everything you'd expect of a nice island in the middle of the Indian Ocean, in the tropical part. When you look at the fatality rate of the pandemic there, which I'm jumping to, it's great relative to other countries. So here's the United States up here. We have a fatality rate, a case fatality rate, not infection fatality rate, but a case fatality rate that's still around 1.6 or 1.7, whatever this is over here. A little bit higher in some other countries, but that's probably just an artifact of testing, et cetera. But Seychelles, much lower fatality rate, which is great. When you look at the amount of virus in places in the region, you see India has a lot, some others have a lot, but there's Seychelles, which is right over here. That's what we're about to get into to see how much they have. Now, what's interesting about Seychelles is, first, let me show you this. When you compare how many people have been vaccinated, Seychelles is actually the #1 country in the world. They beat Israel, they beat the United Kingdom. They have more people who have had at least one dose of the vaccine than any other country. So all eyes are on Seychelles because this is really, really good case study. When you look at the percentage that are double vaccinated, that's this one. Seychelles was way higher than United Kingdom, because remember, UK, again, they only did the one dose was what they were focusing on. It's even a lot higher, not a lot, but meaningfully higher than Israel. So Seychelles is above 60%. Israel is a little bit below 60% in terms of the fully vaccinated. All right, so Seychelles should be doing amazingly well. There should be no virus there at this point, according to our theory of this herd immunity and that the vaccinations are going to stop everything in its tracks. So what does Seychelles look like in terms of their virus? All right, here's Israel down here. Here's United Kingdom. Here is India down here. Here is Seychelles. Their vaccination rate per million people is out of control. If we thought India was out of control, Seychelles is a whole different world. They're in trouble. So what the hell is going on, pardon my French, in Seychelles? So let's dig into this a little bit, because all epidemiologists' eyes are on this. First of all, right now, there's not a lot of genetic screening that's going on there, but we're assuming that they have been struck hard by the B1617.2 variant. Again, the B1617.2 variant is orders of magnitude more contagious. If we thought the UK variant was contagious, this is probably 50% more contagious on top of that. Here's some key facts that are interesting. So there's 2 vaccines that have been largely used there. One of them is the AstraZeneca vaccine. So around 43% of people who are vaccinated got the AstraZeneca vaccine, and 57% received Sinopharm, which was the China vaccine originally. But they're both thought to be very effective. So it shouldn't be the case that that something is so far off with these. It's not like these vaccines were like not good vaccines. They're assumed to be very effective. The companies said that they were around 78% effective at preventing severe disease, according to the clinical trials. And in reality, they're around 50% efficacy rate for the vaccines, which is still pretty decent. All right, but yet what you're finding is that, where was the key number? Was that around, something like 34%. Do you see a 34%? Oh, here it is. 37% of new active cases are people who were fully vaccinated. So that means that roughly 2/3, a little bit less than 2/3 are unvaccinated, which would make sense. It's mostly the unvaccinated. But the fact that so many people were vaccinated in that country, and the ones who are unvaccinated that are so few are still driving this out of control situation, means that there are a lot of unvaccinated people. This is going to hit us. It's going to hit everywhere else in the world, and the vaccination rate is not going to be enough to stop this. The other thing that's that to point out is that there is a difference between people who are getting infected versus people who are needing to be hospitalized or dying. So right now, 80% of patients who are hospitalized are not vaccinated. So we're comparing, so 37% of cases were vaccinated, whereas only 20% of people who are hospitalized are vaccinated. So clearly the vaccines are having a beneficial effect, but there's still, once the unvaccinated population starts to drive a curve that looks like this, it's going to drive a lot of vaccinated people into the hospital. And it's unfortunate, and it's really terrible, and we should be doing a lot more in the United States and globally to vaccinate, but this is going to be hitting us, and we don't know when. And that's the question. So people, don't throw away your masks yet, because we will be wearing our masks again, whether it's fall and winter or earlier than that. That's still yet to be determined, but the masks will be coming back. Those are the main topics there I wanted to talk about for the CDC's decision. Sorry, I just spent so long talking about it, but I figured this is stuff everyone would be very interested in hearing about. There's other questions too that you have, Rebecca.
No, we definitely stop and listen. We know over time when you tell us there's something that really worries you and there's something that is concerning, particularly when we see a graph as striking as this one. I, for one, will be holding on to the mask for quite some time, because this is certainly quite compelling. Oh goodness. All right, everybody. We will remember this case study, that's for sure, Glenn. This definitely is telling us something. Oh, but yes, let's look at this picture. That we like.
Yeah, I like the
That one is
kayak with the
good.
rainbow in the back.
Yeah. Oh yes, I didn't see that rainbow first
Oh,
time
yeah.
around. Oh, that makes me happy. Yeah.
So the big question is going to be, how quickly does this drop? Because what goes up must come down. At some point, it's going to come down, and frankly, that might signal the end. We don't know how severe this is. I mean, obviously, it's driving a lot of people into the hospital, so we know it's extremely severe. However, this should still give us hope. So in Seychelles, despite all the people being hospitalized and all the increase in cases, the case fatality rate is still quite low. So that should give us hope, but it might not tell us a lot. The problem with Seychelles is that it's a very, very small set of islands. Like on this map, you can't even barely see it. And the population, the number of people who live there is very, very small. So because it's such a small sample size, directionally, it's giving us worry. But at the same time, we can't really ask a lot of meaningful questions that we're trying to, because the sample size is not huge.
It is very small. It is. So we do have to keep that into perspective. That is for sure.
Yeah.
Okay. So let's move on to a question that was presented from an audience member about the Pfizer vaccine now being approved for kids age 12 to 15. And how safe and effective is it for this age group? And are there any issues that we should be worried about?
Okay, great. So this curve, you might see, it looks familiar because it's very similar to the original studies that were published based on Moderna and Pfizer. And this tracks very, very closely. You'll notice that so the blue are people who are vaccinated, kids who are vaccinated between the age of 12 and 15. Red are the control group who are unvaccinated. And so in terms of cases that were identified, there's a dramatic effect. In fact, by the second dose, there was not a single new kid that was infected after that in terms of identifying the cases. So it's extremely effective, as we'd expect. When we're looking at safety, no severe issue of any kind. Let me bring this to the top. So these are the side effect profile. They look extremely similar to the adults that we were looking at. The typical things you remember, the top one is the vaccine, bottom is the placebo, the control group. So you'd expect a little bit of fever. Around 2/3 of people report that they were having fatigue. Around 2/3 said that they had a headache. Most of these occurred, so all of these occurred within 7 days after the second dose, but most of them only lasted for a short period of time. Some people had chills and a little bit of muscle pain or joint pain, as well as the injection site sometimes. But that's typically, this seems to be a little bit lower even than the adults were feeling, which is good. But you'll notice even among the placebo, a lot of kids had the same symptoms. So a lot of people, a lot of kids, they get an injection, if they get a shot, they have symptoms because they just are terrified, and so it's some of it's in their mind. But there is a meaningful difference, so it was clearly something's going on. But for a lot of them, it's for most of them, it's not, or for all of them, the symptoms are nothing to be worried about. There was no severe symptoms that were identified in terms of anaphylaxis or anything else that would be concerning, either on the short term or the long term. So this is good news. If you can get your kids vaccinated, if they have access, then don't hesitate, get them vaccinated as soon as they can. There was a controversy among epidemiologists, it's continuing. Is it better at a society level, or even for the United States, for the vaccines to be given to 12 to 15-year-olds, or should we take those vaccine doses and send them to India, send them to other places where the variants are occurring, to try to stop new variants from happening, because that's going to come back. So not only will it help those countries in terms of preventing severe illness and death, but it will also prevent variants from coming back and hitting us. But that's not the way the system works. Right now, it's approved for kids age 12 to 15. If you have kids age 12 to 15, definitely, if they're eligible, make sure they go and get the vaccine ASAP. Good, that's
Excellent.
it.
Yeah, this is great news. I can report here in northern New Jersey, it's actually been quite accessible for kids age 12 to 15. So that has been really good news. I saw a report on one of the news shows that there's been tremendous vaccine hesitancy nationally among parents, somewhere in the 40 to 50% statistically I saw of some parents are really concerned about getting this vaccine for their kids. Fill us in, Glenn. What are you hearing about that?
So let me share with you this, just as a start. Remember when Johnson & Johnson's vaccine was paused a month or so ago? A little bit longer than that at this point. There was a lot of worry. So a lot of epidemiologists thought that was a bad decision, because even though there seemed to be an elevated risk potentially that needed to be evaluated in the Johnson & Johnson vaccine, a lot of us were worried that this would trigger vaccine hesitancy. And so here's what we're looking at. There were the three vaccines, Pfizer, Moderna, and Johnson & Johnson. The pause is the gray area, if you can see it on the screen. You can see that the Johnson & Johnson vaccine was going up. If over this time they continued looking at it, they would have presumably would have had more people. But because of the pause, the Johnson & Johnson vaccine went down to almost nothing. And now the Johnson & Johnson vaccine never recovered. We're nowhere near where the height was back in what was it, sort of the end of April, or sometime in April when this was occurring. And the trajectory is not anywhere near as strong. But even worse, that pause also seems to have been associated with a meaningful decrease in use of Pfizer and Moderna. And so right now, when you compare, let me see if I can pull up this real quickly. I wanted to show this. When you compare, it's up here. When you compare the vaccination rates of different countries, you see that they all start to level off at a certain height. So Israel leveled off at around 60%. United Kingdom was going strong, still going, but it sort of became decreased a little bit when it reached around 50%. Uruguay around 30 to 40% started to decrease and go to slower pace. United States, we've started going at a slower pace around 45%. And I think part of that, we expected based on vaccine hesitancy polls that we'd actually hit a much higher number. But I think it's largely because of the stupid Johnson & Johnson vaccine pause that now we're really having a hard time getting people vaccinated. And it's good to get the kids vaccinated, but we really, really need to get more people over the age of 18 vaccinated. And we're really doing a poor job of that now. And so this is really problematic. In addition to Seychelles that I just said, just in general, it means that we're going to have a lot more spread. People are going to be now taking off their masks. I was talking before about the policy versus the science. The science question, the scientific question about removing the masks among vaccinated, that makes sense. I gave you the sum of evidence for that. The problem is, as a policy intervention, there are a lot of people who are unvaccinated now. They see the people who are vaccinated taking off their masks, and now everyone's just going to be taking off their masks. And so now there's a huge increased disincentive to get vaccinated, because if everyone just sees everyone taking off their masks now, people will interpret this as the epidemic being over. And the problem is the epidemic is not over. It's just that the vaccine is extremely effective and at both reducing transmission and reducing severe disease. And so the problem is now that the epidemic is not over. Every single person who has not been vaccinated is very, very likely to get infected within the next 2 to 3 years. And so a lot of them who have previously been infected are going to get infected again within the next 2 to 3 years. And so this is a real issue as a policy problem versus the science problem. And so this is what we're going to see playing out. But I mean, at some point, the guidance will probably just come back. We're going to have to mask up again and socially distance and all this kind of stuff. All right, Rebecca, was this the last question that you were referring to?
Yeah, well, we're at the top of the hour, and it sounds like there's going to have to be major campaigns once again to just kind of get around these issues. And it sounds like there's major misinformation spreading. And, do you have a sense of what sort of the key misinformation is out there, and what we're up against? And what does it vary by demographic? These are some of the questions that some folks in the audience are asking.
Yeah, it does. So let me pull this up real quickly if I can.
And maybe we'll wrap up with this question. And thanks again to our audience for submitting all of these great questions. Keep them coming like always. Glenn, as you can tell, has done a lot of great research this week preparing answers to these questions. So submit these great questions during the week. Glenn will answer this one, and we'll reconvene next Sunday to answer some more questions.
Thanks, Rebecca. Yeah, so there's been a lot of work trying to identify, looking at focus groups and polls and all these things, working to identify what are people thinking? Is there misinformation that's going around that is why the anti-vaxxers are not willing to get vaccinated? Are some people more susceptible to these questions than others? These are the key narratives that are driving the anti-vaccination folks at this point. So let me just jump into these because they're really interesting. So one is that corrupt elites are making the virus seem more severe than it is, and that the corrupt elites are pushing the vaccines for financial gain. And so this is one of the explanations. Another is the vaccine injury, that a lot of people are worried that they're going to cause deformities or mental illness or microchips or somehow violate us when we get vaccinated. And so there's sort of this idea of injury and 12%, that's really the most important factor for them. For others, it's the sinister origins. So they believe that people who intentionally created the COVID vaccine are shadowy and suspicious. And so they believe that there's some sort of geopolitical power struggle, and that's what's really driving it, that you can't really trust the origins of either the virus or the vaccine. Next is they frame it as a freedom issue, that their freedoms are under siege, and so they don't want to get vaccinated. Even if the vaccine works, they don't want to be forced to take the vaccine. And they feel like when the government, even if the government is not forcing us to do it, even just the vaccine, even if just the government recommending it makes them think that their freedom is under siege. And that's why a sizable, almost 10% of them are saying not to get it. The other is health freedom, so also freedom, but this idea that public health is a matter of individual freedom rather than collective responsibility, They look at it as my body, my choice, as something that applies to vaccines. And they see it as a religious freedom type of free speech type of issue. And all of these are bogus. There's no, when you break down each one, there's good responses for every single one of these. But the problem is, in the minds of people who are choosing not to get vaccinated, these are really what's driving it. And so for people on this call tonight, here are the ways to respond. If you have people in your family or friends or communities who are give you one of these stories, these are the best responses that actually have been found to work based on these focus groups and the studies that have been going on. One is, think of the children. So this frames it as an advocacy campaign to protect the children, that if you get vaccinated, you're actually, actually, this is what, every one of these has a flip. Let me reframe that actually. This is still from the poll. This was misinformation. The one in the red was the misinformation. The rhetorical strategies, rather than simply being misinformation, were rhetorical strategies that were anti-vaccine. So I just misspoke. These are rhetorical qualities that are rhetorical strategies that are for anti-vaxxers. So a lot of anti-vaxxers themselves say, think of the children, as if the vaccines are going to hurt the children, and that's why we can't get vaccinated, because it's going to damage the children. The next thing is, do your own research as a rhetorical strategy, because people who are anti-vaxxers, they're not the physicians or the epidemiologists or the public health experts. They're people who are going to look at Google. So when they're saying do your own research, they have no clue what they're talking about, and they feel just rhetorically that doing your own research means that they're actually doing something and learning. Speak truth to power. Again, this is similar to the freedom type of thing, where they're speaking truth to power, and that's sort of why they're anti-vaxxers. The last thing is panic button, where they tend to have sort of visual cues or audio cues that spark alarm. And so you see this in memes and things that are going around. So whenever you hear someone who is an anti-vaxxer, there's two types of things. They might either have facts that are wrong, that's misinformation, or rhetorical strategies that are wrong, where they're focusing on kids. So for each of these, it's important for us to identify what's really driving their anti-vaccination thinking. And then we can respond to it, because either there's some misinformation that we can target, or rhetorically we can point out, well, no, doing your own research on Google is not the same as experts who are actually doing these clinical trials on tens of thousands of people and looking at the global data, looking at vaccinations, et cetera. So this is really what's driving the anti-vaxxers at this point. In terms of strategies that we found that work that work, I don't know what's going on there. What we're looking at is we still haven't figured out the best strategies to get people to get vaccinated. I mean, as you can see clearly here, we've been doing the vaccination rate is getting lower and lower. I mean, we're going to start seeing a spike again because of all the 12 to 15-year-olds who are not going to get vaccinated. But really, we need to be focusing on the older folks, and that rate is very, very poor right now. And so one of the best strategies we found is offering beer to people, unfortunately. Apparently, despite all the misinformation and rhetorical strategies, simply offering people beer overrides all of these issues that they thought that they had, which is kind of funny. Like, they have all these ideologies, and then you say, oh, well, would you like a beer? And they're like, okay, yes, I'll get vaccinated. But
there were a lot of free donuts being offered as well.
Donuts help, yes.
Yeah.
So we have found some things like that have helped. We haven't found the perfect strategy yet, but I think that we're not doing nearly enough. That's really gonna have to be a focus.
My guess is next week there's going to be some pizza added to the mix. That's my guess.
I hope businesses do more, because there should be an incentive, because come fall, like I said, looking at Seychelles, we're going to be hit with another surge. And so the more people we get vaccinated, the better off we'll be, and the better the economy will be. So the more we can be still just churning out these vaccines over the summer and getting more and more people vaccinated, the better off we're going to be going into the next cold and flu season, pneumonia season, when we know the surge is coming. I mean, the open question is whether the summer sees a surge, depending on what the spread looks like. And already what I shared with you here is that when you look at the states that are being hit, this is vaccine. Let's look at cases. When you look at the states here that are being hit, you see that the South right now is doing pretty well. Florida is not. A couple other states in the South are not doing so well. The summer surge last year was bad, and there's no reason why theoretically we wouldn't see another surge this summer, because we don't really know exactly why it happened last summer. We do know that there was an age difference, so this was kind of curious. So I'll end here. But so when you look at what drove the age difference last year, in fact, I already have this open. I can just jump to it here. All right, so when you look at the second surge, this was the older, so this was 80 years and over here. When you look at the light green, the dotted were the 18 to 24-year-olds. The dashed here were the 25 to 34-year-olds. The surge last summer was almost all, you can see, driven by these 18 to 24-year-olds and 25 to 34. The 35 to 54-year-olds were also driving it a close behind there, but it was really not the same as you see in this surge now, where you had a lot of older people and the kids driving it. Just the opposite. It was really the college age kids, the 18 to 24 and the 25 to 34-year-olds. People going out to the bars, people going out to party, that's what drove the second surge. And so now the worry is, well, that could easily drive another surge this summer too. So it's an open question, but I mean, we can make our own guesses about what will happen this summer. But either way, there's not really much doubt about what we're going to see in come fall and winter.
Goodness. All right. Till we meet again, we thank you, Glenn, for all of the hard work you put in week after week. We are so appreciative of your expertise, and thank you to everybody for sharing so many great questions. Keep them coming. Have a very safe week, everybody. Be well. See you next Sunday. Take care. Bye-bye.
Thanks, Rebecca. Thanks, everyone. Bye-bye.
Thank you.